Hi friends, once again welcoming you all back to the Nurse channel. I hope you all have completed the registration process for the upcoming AIIMS NORCET examination because the last date for the application is nearing. So whoever not yet applied, kindly do it first. And at the same time, the notification link for the ESIC examination has already arrived. And I request everyone who are planning to apply for the ESIC post, kindly do it first because the desired exam center, if you want to choose a particular exam center, that exam center, they have kept some numbers. Okay, so if you want to get the desired exam center, do it first. Okay, so keeping these two examinations in mind, we have already started a series to crack these examinations, and this is another set of important 15 questions that is coming to your way, and that these questions will definitely help you to prepare better for your upcoming examination. And the explanatory sessions of each questions are very important. So like our previous videos, I am telling you the explanatory sessions and the points what I am going to discuss in the explanatory sessions are also very important. So I request everyone who are watching this video to watch the video till the end without skipping. Okay, and one request, whoever not yet subscribed our channel, kindly subscribe and support us and enable the bell button so that you will be notified whenever we are uploading new videos. So without losing time, we will move on to the another 15 important questions in our series, that is the AIIMS NORCET and the ESIC series. So let us begin this new session with a tricky question, and your first question is in the screen right now. So the question is, which among the following diseases is associated with excess build up of copper in the body? So the question is regarding excess deposition of copper. Excess copper deposition can result in development of which disease? So the options are option number A, Wilson's disease, option number B, Wilms tumor, option number C, West syndrome, and option number D, Wernicke's encephalopathy. So which is associated with excess copper deposition in the body? So the answer is option number A, that is the Wilson's disease. Wilson's disease. So we will be seeing all these options now. So first of all, Wilson's disease, it is a genetic disorder in which excess copper builds up in the body, and the symptoms are typically related to brain and liver. Okay, so the main two organs which are affected by the Wilson's disease is the brain and the liver. So the symptoms can be explained under two headings, that is the brain symptoms and the liver symptoms. So first of all, the liver related symptoms include vomiting, weakness, then fluid buildup in the abdomen, ascites, then swelling of the legs, yellowish skin and itchiness. Okay, yellowish skin and itchiness. These are the liver manifestations. Then the brain related symptoms include tremors, muscle stiffness, trouble in speaking, personality changes, anxiety and psychosis. Okay, so this is regarding, in short, regarding the Wilson's disease. So excess copper deposition in the brain and in the liver. So we have liver manifestations and brain manifestations. Okay, so that's all regarding Wilson's disease. Then the other option, Wilms tumor, okay, also known as the nephroblastoma. So you know that it is a cancer of the kidney that typically occurs in the children and can happen very rarely in the adults, and it occurs most commonly as a renal tumor in child patients. Okay, Wilms tumor or the nephroblastoma. Then another option was the West syndrome, otherwise known as the epileptic spasms. Okay, so it is an uncommon to rare epileptic disorder in infants, and the epileptic seizures which are observed in infants with West syndrome are fall into three categories, which is known as the infantile spasm. Okay, so I'm not going to explain in detail about this West syndrome and all, you can refer it later. So this name and all is very important in exam point of view. Okay, so infantile spasms can be seen in which disease condition? Like that questions can come, that is epileptic spasm or the West syndrome. And the final option was the Wernicke's encephalopathy. You know that it is otherwise known as the wet brain, and it is the presence of neurological symptoms caused by the biochemical lesion of the central nervous system after exhaustion of the B vitamin reserves, especially vitamin B1. That is because of the deficiency of B1 or the thiamine, Wernicke's encephalopathy or the wet brain can happen. Okay, So that's all regarding the first question. So you are getting information regarding 4 disease conditions which are starting with the letter W. Okay. So with that we are be moving to the next question in the series from orthopedics. Which type of bone tissue is involved in calcium storage? So which type of bone tissue is involved in calcium storage? So options are option number A, compact bone, number B, spongy bone, C, cartilage, and D, ligaments. So which one is involved in calcium storage? So the answer is option number B, that is a spongy bone. Spongy bone. Okay. So we know that spongy bone, also known as a cancellous bone, it contains trabeculae. Trabeculae means a lattice-like structure with spaces filled with the red bone marrow. So okay, this type of bone tissue is involved in the calcium storage and the production of red blood cells, that is the hematopoiesis. Okay. So again, very important points you are getting. Then spongy bone, they are also known as the trabecular bone, and it is a porous honeycomb-like tissue found at the ends of the long bones, and it is also found in the pelvic bones, ribs, skull bones, and the vertebrae. Okay, so in this part the calcium storage is happening. Okay, then the other options we will see. What is a compact bone? Compact bone, otherwise known as the cortical bone, it is a hard, dense outer layer of the bones, and it is made up of closely packed osteons or the Harvesian systems. And the spaces within the compact bone are much smaller, making it denser than the spongy bone. Okay, so the spaces are very small in this because it is very dense, okay, compared to the spongy bone. So that is a compact bone, then the spongy bone. So moving on to the third question in our series, what is the most common type of surgical incision? So you have come up across several types of surgical incisions, but here the question is, which is the most common type of surgical incision? So the options are A, longitudinal incision, option number B, transverse incision, option number C, lateral incision, and option number D, medial incision. So which is the most common type of surgical incision? So the answer is option number B, that is a transverse incision. Okay, so with the help of this picture we can explain this. So transverse incision is the most common type used in the surgical procedures, and it is made horizontally across the skin, and it is typically used for the procedure where access to the underlying structures is needed. Okay, so this is a most common type of surgical incision. Then comes the midline abdominal incision. You can see the incision here. Midline abdominal incision is made vertically. It is made vertically in the midline of the abdomen, and this type of incision provides optimal access to the liver. Okay, optimal access to the liver and other abdominal organs. Okay, so liver and other abdominal organs, that is a midline abdominal incision. Okay, so some another important information, while midline incisions provide good access to the abdominal organs, they often result in greater post-operative pain compared to other types of incisions. Okay, so this is the answer for another question, which surgical incision can cause maximum pain to the patient? That is the midline abdominal incisions. Okay, so this is due to the fact that the incisions cuts through many sensory nerves in the abdominal wall, leading to more pain during the healing process. Okay, so these are some additional information you are getting out of this question. So that's all regarding that question. Now we can see the fourth question in our series. So the question is, what is the most common clinical presentation of Meckel's diverticulum in children? So what is Meckel's diverticulum, that you have to know, then only you can answer this question. So here the question is most common clinical presentation. Options are hematemesis, option number B, hematochezia, option number C, abdominal pain, and option number D, biliary colic. So it is the most common clinical presentation of Meckel's diverticulum. So the answer is option number B, that is hematochezia. Hematochezia. So you know that Meckel's diverticulum, it is a true congenital diverticulum, which is a slight bulge in the small intestine which is present at birth. Slight bulge in the small intestine which is present at the birth, and a vestigial remnant of the vitelline duct. Okay, So it is the most common malformation of the gastrointestinal tract and is present in approximately 2% of the population, with the males more frequently experiencing the symptoms. Okay, so some bunch of information from this slide. What is a Meckel's diverticulum? So which is the vestigial remnant in Meckel's diverticulum, that is a vitelline duct, and this is the most common malformation of the gastrointestinal tract, and it can affect more males than females. Okay. Then the most common clinical presentation of the Meckel's diverticulum in children is the painless rectal bleeding, otherwise known as the hematochezia, painless rectal bleeding. And in adults, it may present with complications such as diverticulitis, obstruction, or perforation. Okay, it can go to complications like diverticulitis, obstruction, or perforation. Painless rectal bleeding known as the hematochezia. Okay, so that's all regarding that fourth question. Now we will move on to the fifth question, and the question is, which of the following is not a paranasal sinus? Okay, so you know the sinuses. So the question is, which is not a paranasal sinus? And the options are: option A, maxillary sinus; option B, frontal sinus; option C, temporal sinus; and option D, sphenoid sinus. Maxillary, frontal, temporal, sphenoid. Slightly confusing but easy question. Answer is definitely option number C, that is a temporal sinus. So we will explain this paranasal sinuses with the help of a diagram. So here in this diagram you can see that the four paranasal sinuses. So before it, what is a paranasal sinus? These are the air-filled cavities located within the bones of the skull. Okay, so they are named after the bones they are located in. So for example, we have the maxillary sinus. You can see the maxillary sinus here. The maxillary, it is located under the eyes. Okay, maxillary sinus which are located under the eyes. Then the frontal sinuses which are located in the lower forehead. So this is the forehead. So in the lower forehead we can see the frontal sinus. Then comes the ethmoid sinus which is located beside the upper nose. Okay, ethmoid sinus beside the upper nose, you can see here, this is the ethmoid sinus. See here is the ethmoid sinus, and then comes the sphenoid sinus which is located behind the nose. Okay, so here you can see the sphenoid. Okay, in this it is not visible, so in the behind the nose we can see the another sinus, that is a sphenoid sinus. So these are the four paranasal sinuses, that is a maxillary, frontal, ethmoid, and sphenoid sinuses. Then in the question I have given another sinus, that is a temporal sinus. So temporal sinus, on the other hand, it is a venous sinus that runs in the dura mater, a layer of the tissue covering the brain. Okay, from the dura mater some venous drainage is happening through a sinus which is known as the temporal sinus, and this is not at all related to the paranasal sinuses. Okay, so to confuse you, this question has been given. Okay. So that's all regarding that question. Now we will move on to the sixth question in our series. So hydrocele occurs in which layer of testicle? So hydrocele occurs in which layer of testicles? So hydrocele, you know that it is a fluid collection in the testicle. So here the question is, in which layer this is happening? So option number A, tunica vaginalis; option number B, tunica albuginea; option number C, tunica vasculosa; and option number D, tunica intima. So in these three options are the layers of the testicle, and the one is not related to testicle. So what is the answer? That we will explain in the explanatory session. So the answer for this question is option number A, that is a tunica vaginalis. So hydrocele, a hydrocele testis, it is an accumulation of clear fluid within the cavum vaginale. Cavum vaginale, the potential space between the layers of the tunica vaginalis of the testicle. Okay, so it is in the fluid collection in the cavum vaginale, it is a potential space between the layers of tunica vaginalis. So it is the most common form of the hydrocele, and it is often referred to simply as the hydrocele. Okay, so which all are the layers of testis, that we have to understand, then only we can answer these questions. So the testes are covered by three layers, three protective coverings called tunicae, and they are externally covered by tunica vaginalis, that is the external cover. Then next comes the white fibrous membrane called as the tunica albuginea. Then comes the last innermost layer, that is known as the tunica vasculosa. Okay, so remember these 3 points: tunica vaginalis, it is the outermost covering. Then comes the white fibrous membrane, that is a tunica albuginea, and the innermost one is the tunica vasculosa. So here the question was regarding the hydrocele, which is happening in the tunica vaginalis level. Okay. So that's all regarding that informative question. We will move on to the 7th question in our series. So what is the first line treatment for nephrotic syndrome aimed at reducing the proteinuria? So 2 points you have to take from this question. The first one is nephrotic syndrome first line treatment, and then the second one is it should aim at reducing the proteinuria. Okay, so which is the drug, which is the management? So the options are option number A, diuretics, option number B, ACE inhibitors, option number C, antibiotics, and option number D, corticosteroids. So think about nephrotic syndrome, and one symptom already they have given in the question, that is a proteinuria. So what is the answer? So the answer is option number B, that is the ACE inhibitors. Okay, ACE inhibitors. So you know that nephrotic syndrome is recognized by the presence of proteinuria in excess of 3.5 gram per 24 hours, along with hypoalbuminemia, then edema, hyperlipidemia, and lipiduria. So these are the features what we can see in the nephrotic syndrome. Very, very important. So there will be proteinuria, that means in excess of 3.5 gram per 24 hours. Then there will be hypoalbuminemia, that is a reduced albumin level in the blood. Then edema will be there, that is a fluid collections. Then hyperlipidemia, like cholesterols and all. Then that is hypertriglyceridemia and hypercholesterolemia. Then lipiduria means lossage in the urine. Okay, so these are the features. So coming to the question, angiotensin converting enzyme or the ACE inhibitors are angiotensin 2 receptor blockers, which are the first line treatment for the nephrotic syndrome in patients with secondary nephrotic syndrome. Okay, these medications lower the amount of protein in the urine. So the amount of protein in the urine can be reduced with the help of angiotensin converting enzymes. Okay. So that's all regarding that question. Moving on to the 8th question from the community health medicine. So which of the following is not a common symptom of typhoid fever? So here the question is regarding the typhoid fever, and which is not a common symptom of typhoid fever. That is a question, and the options are option number A, rash, option number B, cough, option number C, diarrhea, and option number D, constipation. So which is not a common symptom of typhoid fever? So the answer is option number B, that is cough. Cough is the answer. So you know that typhoid fever, it is a life-threatening infection which is caused by the bacterium Salmonella typhi, and it's usually spread through contaminated food and water. So coming to the question, so the early symptoms of the typhoid fever includes the fever that starts low and increases throughout the day, possibly reaching as high as 104 degree Fahrenheit. Okay, so fever that starts low, it will be low and it will elevate to the highest level in the day, that is a 104 degree Fahrenheit, that means 40 degrees Celsius up to. Then there will be chills, headache, weakness and fatigue. Then muscle ache and stomach ache will be there. Diarrhea and constipation will be there, and finally a typical rash will be there. So these are the early manifestations of the typhoid fever. In this, cough is not there. So we know that typhoid fever can cause a typical rash called as the rose spots, which are small red spots which are seen on the abdomen and the chest. And the spots are pink and tend to last around 3 to 5 days. Okay, they are pink and can last for 3 to 5 days. And rose spots usually occur between the 2nd and 4th week of the illness. Okay, so these are the rash characteristics of the typhoid fever. Okay, and regarding the cough, I told already, there a cough can occur in some cases of typhoid fever and it is not a common symptom, and the other symptoms such as the rash, diarrhea, constipation are more commonly associated with this disease. That already we have explained. Okay, so you are getting information like what is a typhoid fever, what is a causative organism, what are the early signs and symptoms of the disease, and what are the peculiarities of the rash which you can see in the typhoid fever. Okay, So that's all regarding that question. Moving on to the 9th question in our series, which is an application level question. The nurse notes air entering the patient via the central line while administering total parenteral nutrition. So which initial action is most appropriate? So you have seen that the air is entering into the central line while you are administering TPN. So what could be your what is your initial most appropriate action? So the options are: option number A, you should notify the physician. Option number B, you have to elevate the head of the bed. Option number C, place the client in the left lateral decubitus position. And option number D, stop the total parenteral nutrition and hang a D5 half NS. Half dextrosaline. So what is the answer? Air is entering into the central line. Your action. So definitely your action is option number B. Place the client in the left lateral decubitus position. Why? So that we'll be seeing now. So for the venous air emboli, immediately place the patient in the left lateral decubitus and Trendelenburg position. Okay. Left lateral decubitus plus Trendelenburg we have to give, and this is known as the Durant maneuver. Okay. Durant maneuver for the venous air emboli. Okay, so this helps to prevent air from traveling through the right side of the heart into the pulmonary arteries, which can lead to right ventricular flow obstruction. So to prevent this airlock, we should place the patient in the left lateral decubitus plus Trendelenburg position. So that is a Durant maneuver. Okay, informative question. Now we can move on to the 10th question in our series. Which among the following is not a type of breech presentation? Okay, again one question from the obstetrics, which is not a type of breech presentation. So the options are complete. Option number B, in mentum transverse. Option number C, incomplete. And option number D, frank. So which among this is not a type of breech presentation? So the answer is option number B, that is a mentum transverse. Mentum transverse. Okay. So mentum transverse is a chin presentation that we will see now. So first of all, these are the variations of the breech presentation. You can see complete breech, incomplete breech, and the frank breech. So there are three types of breech presentation. So in the complete breech, what is happening is when both of the baby's knees, see, both of the baby's knees are bent and his feet and bottom are closest to the birth canal. Okay, so here the feet, the bottom is close to the birth canal. Here comes the birth canal. So that is a complete breech. But in the incomplete breech, here the baby's knees is bent and his foot and bottom, one of the baby's knees is bent. Okay, one knee is bent, then and the bottom of the baby and the foot of the baby is closest to the birth canal. But in the frank breech, you can see that the fetus has flexion of the both hips. Okay, both hips flexion is there and the legs are straight with the feet near the fetal face, and the feet is here near the fetal face, and it is in a pike position. Okay, it is in the pike position. So these are the three types of breech presentation. I think you got the point with the help of this diagram: complete, incomplete, and frank breech. Now mentum anterior, that was another option what I have given. So based on the position of the chin, the face presentation can be further divided into mentum anterior, mentum posterior, or transverse. Okay, that you can learn later. So now we will see the next question in our series. So the 11th question: which of the following is not a risk factor for the development of cervical cancer? So here the question is regarding the cervical cancer, which is not a risk factor for cervical cancer. So the options are: option number A, smoking; option number B, early onset of sexual activity; then option number C, multiple sexual partners; and option number D, unopposed estrogen exposure. So we already have explained and discussed regarding the cervical cancer and some other points in our older video. So this also you can is another important point that you have to remember in exam point of view. So cervical cancer, which is not a common risk factor. So the answer is option number D, that is unopposed estrogen exposure. Okay, unexposed estrogen exposure. So you know that the cervical estrogen exposure is not at all a risk factor for the development of cervical cancer. Then which cancer? That I will be explaining in the explanatory session. So early onset of the sexual activity and the multiple sexual partners, this increases the risk for the cervical cancer, because there will be likely there is a chances of increased potential exposure to the HPV virus, that is a human papilloma virus. And you know the connection between the HPV and the development of cervical cancer. Okay, so that is a early sexual activity and multiple sexual partners are definitely risk factors of cervical cancer. And cigarette smoking, as you know, as of like any other cancers, cigarette smoking is an independent risk factor for the development of cervical malignancy. Then I asked you a question, how the estrogen can, high levels of estrogen can result in which type of cancer. So the studies have shown that a woman's risk for the breast cancer is related to the estrogen and progesterone made by her ovaries, which are known as the endogenous estrogen and progesterone. Okay, so definitely being exposed for a long time and or to a high levels of these hormones like estrogen and progesterone has been linked to the increased risk of breast cancer. Okay, so this is an additional information. Increased levels of estrogen and progesterone can have a possibility of developing breast cancer. Okay, so that's all regarding that question. We will move on to the 12th question in our series. So here the question is, you have to identify the correct order of the wound healing process. So which is the correct order of wound healing process? So the option number A, hemostasis, inflammation, proliferation and remodeling. Then hemostasis, proliferation, inflammation and remodeling. Then inflammation, hemostasis, proliferation and remodeling. And finally hemostasis, inflammation, remodeling and proliferation. So which is the correct order of the wound healing process? So wound healing process, these things are very important in exam point of view. So what is the order? The answer is option number A, that is hemostasis, inflammation, proliferation and remodeling. So you can remember like hip. Okay, hemostasis, H for hemostasis, I for inflammation, P for proliferation and R for remodeling. So we will see each stages in very short, very important points in exam point of view. So hemostasis or the blood clotting, and within the first few minutes of injury, platelets in the blood begin to stick to the injured site. Okay, so here starts the the blood clotting or the hemostasis stage. And there are so many other things are happening during this stage. Whatever important in exam point of view I am explaining now. In detail if you want means you can refer later. So the first few minutes, that is the hemostasis. Then comes the inflammation. So during this phase, the damaged and the dead cells are cleared out, and along with the bacteria and other pathogens or the debris. And this happens through the process of phagocytosis, okay, by W basis. So the duration of these phase is 4 days. Okay, in the wound healing process, the inflammatory phase lasts for nearly 4 days. So what is happening is that the dead cells, the damaged cells, then the bacteria and the other pathogens are removed by the process known as the phagocytosis. So that is inflammatory phase. Then next comes the proliferatory phase or the growth of new tissues. So in this phase, there will be angiogenesis, that is the vascular development will happen. Then the collagen deposition will happen, granulation tissue formation will happen, epithelialization and the wound contraction also will occur. Okay, so again I am telling you these are some key points, and in detail you can refer later. And this proliferatory phase will last for nearly 2 weeks. So you can get questions like angiogenesis or the vascularization of the wound can happen in the which phase of wound healing? That is in the proliferation or the growth of new tissues. Then the last stage, that is a remodeling phase or the maturation phase. So during the maturation and remodeling, the collagen is realigned. So collagen deposition is happening during the proliferation phase, but this collagen is realigned along the tension lines during the maturation phase. and along with that the cells that are no longer needed are removed by the programmed cell death, otherwise known as the apoptosis. So this is another important point. What is programmed cell death and in which phase of wound healing this is happening? Another important points. So this can happen from 24 days to year. Okay, the remodeling can happen from 24 days to year. Okay, so these are the phases: hemostasis, inflammation, proliferation, and maturation. Very, very, very important in exam point of view. Okay, so with that informative question, we will be moving to the next question in our series, that is the 13th question. So the question is, which tool is used for the documentation of healing of already developed pressure ulcer? So from the question, you should be very careful that here already the bed sore is developed. So to know the degree or the healing status of the pressure sore, which tool is used? So don't be confused. So the options are: option number A, that is a Braden scale; option number B, PSST; option number C, PUSH or the push; and option number D, both PSST and push. So you will be aware of some of the scales I have mentioned here. So think about the point, bed sore is already happened. Okay, so then which scale is used? So the answer for this question is option number D, that is PSST and the push scale. Okay, that we will see now. So first, pressure source risk assessment is done by the Braden scale. Okay, so here the pressure score risk assessment is doing that. The pressure score is not developed yet, but the risk we are assessing during the scale with the scale that is known as the Braden scale. Okay, so in Braden scale, you know that 6 factors are considered, which include the sensory perception, moisture, activity, mobility, nutrition, friction, and shear. Okay, friction and shear. So these are the points that we have to see while assessing the risk for development of pressure sore using the Braden scale. Okay, so numerous scores are given against each factors, like total scores can range from 6 to 23, and you know that the lower the score on the Braden scale, the higher is the risk for development of pressure ulcer. Okay, the score is less means there is higher chances for developing the pressure ulcer. So why I am explaining this much is, from this areas many questions can be asked, like how many factors are assessing in the pressure sore in the Braden scale, what are the numerical scores of the Braden scale, then how the scores will be assessed, like how the pressure sore risk will be there based upon the score. Okay, this is regarding the Braden scale. Now we will come to the answer for our question. So the pressure ulcer scale of healing, otherwise known as the push tool, and the pressure sore status tool. Okay, pressure sore status tool, that is a PSST, pressure sore status tool. These are the tools which are used for the documentation of the healing of already developed pressure ulcer and not to assess the risk of pressure ulcer. Okay, so each tool we will see just very briefly. So the pressure ulcer scale for healing, otherwise known as the push, it is a free paper and pencil tool that measures the change in the pressure ulcer status over the time, and the push is a clinically practical tool that can accurately distinguish between the healing and non-healing ulcers. Okay, and it grades the pressure ulcers based on the wound size, the wound bed tissue type, and the exudate amount. Okay, so these are the things which are assessing in the push scale, that is a pressure ulcer scale for healing. Then comes the PSST scale, that is a pressure sore status tool. Now it is known as the Bates-Jensen wound assessment tool, otherwise known as the BWAT tool. So again, it is a 15-item tool which is used to assess the wound healing and its status. Okay, so this is another tool, that is a PSST, pressure sore status tool. Okay, so with that we are coming to the next question, that is the second last question. What is the treatment for herpes zoster? Treatment for herpes zoster include dash herpes zoster. So the options are: option number A, tetracycline; option number B, liquid nitrogen; option number C, famciclovir; and option number D, meconazole. So what is the treatment option for herpes zoster? Answer is option number C, that is a FAMC clover. FAMC clover is the answer. So we know that the herpes zoster occurs due to the activation of the varicella zoster virus, and the treatment of herpes zoster usually include administration of an antiviral agent, that is FAMC clover. Okay, so other option we'll have a look, that's a tetracycline. You know that it is an oral antibiotic in the tetracycline family, and it is used to treat a number of infections which include acne, cholera, brucellosis, plague, malaria, and syphilis. Okay, so keep these points in mind: cholera, brucellosis, plague, malaria, and syphilis. Okay, so these are some community-based infections that where the tetracycline is used. Okay. Then another option was regarding the liquid nitrogen. Liquid nitrogen is otherwise known as the cryotherapy. Cryotherapy. So another answer for another question. So in cryotherapy, which element is used? Which substance is used for the cryotherapy? That is a liquid. That liquid nitrogen, and it is a treatment that uses freezing to destroy the abnormal or the unwanted tissue. And liquid nitrogen is a chemical that is extremely cold, which is about 328 degree Fahrenheit. That means minus 328 degree Fahrenheit, that is minus 200 degree Celsius. That is liquid nitrogen. And the treatment options are with the liquid nitrogen is for the warts, keratosis, superficial hemangiomas, leukoplakias, keloids, superficial scarring, and dermatitis venenata. Okay, so these are the disease conditions where liquid nitrogen or the cryotherapy is indicated. Okay, cryotherapy, important point. Then comes another option what I have given, that is a Meconazole. So Meconazole is used to treat the skin infections such as athlete's foot, then jock itch, ringworm, and other fungal skin infections like candidiasis. Okay, that tinea related things that you can remember. Okay, tinea that can be treated with the Meconazole. Okay, so that question is understood for you. Now we will move on to the last question in the series. So easy question, but is a very important question. The most common sites of herniation of an intervertebral disc is. So as far as the nurses and the long-standing professionals are concerned, there are chances like there will be disc prolapses. Okay, herniation of the disc can happen. So which is the most common site of herniation? That is the question. So the options are option number A, L1, L2 and L2, L3. Option number B, L4, L5 and L5, S1. Option number C, C5, C6 and C6, C7. And option number D, C3, C4 and C4, C5. So this is a very important question in exam point of view. I think it has several times it was asked in the previous examinations. So the answer is option number B, that is L4, L5 and L5, S1. L4, L5 and L5, S1. So herniation of the intervertebral disc may occur at any level, but most common sites of the herniation are L4, L5 and L5, S1. So this is a common problem of a long-standing professionals, especially nurses. So with that informative question, we are coming to end of another important series of the AIIMS NORCET and the ESIC. So hope these all 15 questions what I have explained here is very important, and these questions are helpful for your preparation, and the explanatory sessions for each questions were also very important. So kindly share about this platform to your nursing friends and kindly stay in touch with us. We will be uploading the next set of questions very shortly. So till that time, stay in touch. Best wishes for your examination. Thank you.